and welcome to Wellness Live. My name is Dr. Olivia Moses, and I'm the Assistant Vice President for Corporate Health and Wellness right here at Loma University Health. And this broadcast is brought to you by the Department of Risk Management. Well, today we are going to be talking about a very, very important topic. And if you are new to Wellness Live, we have these sessions every month. And today we are talking about mental health. We have a wonderful speaker here today. And why should we be talking about mental health? Well, it is part of our wellness. And a lot of times we don't really take it seriously. And what I mean by that is sometimes we are scared to address it. Sometimes we think we need to push our way through it. Sometimes we don't go to the right specialist at the right time. So we want to address some of these things today with you, with our guest speaker today, Dr. Ariana Martinez. And she is a child and adolescent psychologist right here at Loma Linda and a professor at our School of Medicine. And she's a perfect person to talk to us about maybe non-medical interventions for mental health. And we want to talk about a broad topic here about mental health, but we have an opportunity to ask her specific questions. So if you are watching us live, go ahead and type in your questions and we can ask her directly some questions right from you. So without further ado, I'd like to introduce you to Dr. Martinez.
Thank you so much. Well, I was really honored to be invited to speak and also excited to share about one of my personal favorite areas of research connected to my field of practice as a psychiatrist. Now, as I get started, just need to mention I have no conflicts of interest to disclose about today's presentation. So the origin behind the title for today's presentation, "To Give Sorrow Words," is a line from Macbeth written by Shakespeare, which reads, "Give sorrow words, for the grief that does not speak whispers the o'erfraught heart and bids it break." And the reason why this stood out to me is it really highlights and kind of focuses on the often overlooked tool of putting feelings into words, which is a technique we call affect labeling. And this is an emotion regulation strategy, one of the non-medication types of interventions that we can really present and give to patients to utilize in our mental health treatment. And this carries significant potential for benefit both on the affective or experiential level, but also on the neurobiological, which is what we're going to really review over today. And another thing that really made this line stand out to me was that it highlights the negative repercussions of when we fail to practice affect labeling as well. So throughout the course of this presentation, I'm hoping for listeners today that we can equip you with kind of an understanding of some of the theories and definitions related to emotion regulation and an understanding of the methods that we can use to measure that. Also equip you with an understanding, at least basically of the neural regions that are involved in emotion regulation. Review a few of the studies that really have kind of highlighted or given us answers as far as to what the mechanism of affect labeling is. And then throughout this time period, just emphasize the clinical usefulness of this technique that you can implement into either your life or for the providers out there for your practice. So jumping on in, there's kind of three theories or beliefs that people might hold about the relationship between our emotions and the attention or the language that we direct towards them. The first is that emotional language, saying something like, "I feel scared," would have no impact on the emotion itself. Whereas the second theory is the one actually most commonly held by society. Those around you, most of them are probably going to hold this understanding that essentially emotional language can amplify one's emotional states. And in this paradigm or this belief, making a statement like, "I feel angry," would actually lead to me feeling more angry, almost as if giving attention to or increasing awareness of the uncomfortable emotion would lead to its amplification. And holding this belief, as you might imagine, will result in people when they experience an uncomfortable emotion to kind of intuitively try to push it away or try to distract themselves from that experience. And this on a very short-term basis could be seen potentially as non-harmful, but if sustained long-term, can really lead to some quite negative outcomes and may result in the magnification of what we were actively trying to avoid in the first place, these emotions kind of intensifying or getting out of control or getting in the way of us doing what we need to do. So contrast that to the third theory or belief, which is the one we're going to be looking at most today, through reviewing some of the results of various studies, which really support this understanding. And that is that the use of emotion identification language, particularly of uncomfortable emotions, actually serves to diminish their intensity. much more effectively than that previous strategy. This would allow us to be productive or complete tasks that perhaps the emotional state was interfering with. And now, as we're getting into this discussion, I realize I've been mentioning a few terms like emotional language, emotion regulation, a few things quite a bit. So we're going to take a moment to review some of the important definitions, which will be woven into our discussion and important for understanding some of the studies that we'll be reviewing. So to start off with, emotion regulation, which I've said a few times, really refers to the process by which we as individuals influence our emotions, how we experience them, express them, manage them, and it encompasses a pretty broad range of strategies and mechanisms that people can use to monitor, evaluate, or modify our emotional responses in different contexts. Emotion regulation can also take various forms, including things like suppression, cognitive reappraisal, mindfulness, and the focus of today, affect labeling. But just to give you again an understanding or definition of a few of these terms that really come very close together in discussions, mindfulness is really just a process of bringing awareness and receptiveness to present moment experiences. And for most people's practices, it also includes this emphasis on calmly acknowledging and accepting what one's feelings, thoughts, or bodily sensations, and is really often used as a therapeutic technique. Reappraisal, on the other hand, is a technique by which we reframe the meaning of an event so as to change its emotional significance and impact. So, kind of most concisely, I conceptualize this as the ability to find the silver lining in a situation. So, an example would be maybe you get really tough feedback at work about your job performance, and initially you might feel pretty distressed, like frustrated, saddened, maybe quite a number of emotions going through you, which could impact you quite negatively. But if you're engaging in reappraisal, what you might do is take stock of that feedback that you've received and try to internalize it in a way as an opportunity for growth, seeing it as constructive criticism and something that will make you better in the long term. So that would really change how you're interpreting and how it impacts you. And then let's put this side by side to really the most simple, I feel, of all emotion regulation techniques, affect labeling. And this is the action or tool or technique of putting feelings into words or naming our emotions. And again, this is the primary focus of the studies we're going to be reviewing today. And the reason why I absolutely love it is that it's profoundly simple. It's not terribly nuanced. There's no requirement for guided meditation, facilitation from a professional. There's much less mental gymnastics involved than reappraisal. This is an extremely quick, efficient, and accessible tool which can be done in a matter of seconds, no matter where you are. So the idea of affect labeling is that instead of trying to push away an uncomfortable emotion, to actually draw closer to it by feeling it, identifying it, and putting a label on it. And based on a few other studies, this really can be done best for best results either verbally, so stating this out loud, or through writing. But this might feel like a bit of a claim to make. So you might be asking yourself, like, how can we really determine that affect labeling, this action of putting feelings into words, saying something like, I feel angry or I feel scared, would have a beneficial impact? And the way that we determine this effectiveness of emotion regulation techniques like affect labeling is by utilizing certain modalities, both subjective and objective. And just as a note, something that I've always struggled with in my field is that much of our data, both in research and in clinical diagnosis, comes from what we consider very subjective markers. So the things that we'll find in like the review of our experiential or behavioral domains of measurable effects of emotion changes or interventions. Again, this is something that I sometimes struggle with because there can be quite an amount of bias built into those modalities of feedback. But what's exciting about some of the research we're going to go over today is that there's really a growing body of evidence tracking very objective markers, such as what we can measure in the neurological realm. And for our purposes today, the studies we're going to be reviewing, the primary modality that they used for measuring the impact of affect labeling was functional MRI. So this is a type of brain imaging that measures brain activity by detecting changes in blood flow. And when a brain region is more active, it consumes more oxygen, and the fMRI can capture this change in the blood flow. Unlike regular fMRI, which really just shows the structure of the brain, functional MRI focuses on how different areas of the brain are active during specific tasks or activities. And it's through this modality that the mechanisms by which affect labeling produces its benefit have been able to be discovered. Previous to this, it was really largely unknown why we saw so much benefit in our subjective markers of experiential or behavioral domains. And why this is really exciting to me as well is that this incredibly simple tool of affect labeling has been found to have very robust evidence for observable significant differences in activities of specific brain regions. The next objective measurable category is that of physiological indicators. So things like skin conductance, heart rate variability. I had a chance to be involved in some research as a medical student and resident where we had individuals connected to some of these physiological marking or measurable techniques, and we observed those changes while they were recounting positive and negative experiences with their medical supervisors. The next category is experiential. This, for a lot of providers, they might be more familiar with. Things like body sensation maps, self-questionnaires like Beck Depression Inventory, PHQ-9. You see those really commonly being utilized in clinical settings. And then last but not least, we do have behavioral outcome measures, things related to functionality in terms of school performance and work performance. So again, these are all the domains by which we can measure the effects of emotion regulation techniques like affect labeling, but today's focus we're going to look at is going to be within the neurological domain. Now, as we jump into our fMRI studies, it's important to have at least just kind of a basic understanding of certain neural regions as well. So the human brain, we often conceptualize in terms of its different functions, particularly when we're distinguishing between the more primitive, emotional, and then higher order cognitive processes. So in terms of the primitive brain, what you see there in the red picture, this includes the brainstem, which is really responsible for basic life functions, things like breathing, heart rate, sleep-wake cycles, etc. Whereas moving to what we'd kind of conceptualize very broad stroke terms as the feeling part of the brain, this is the limbic system. And this is a set of structures in the brain that are primarily responsible for emotions, memories, and arousal. And the amygdala, which is going to be a key player in our discussion today, is a really important part of the limbic system. And then contrast this to what we'd consider the thinking part of the brain, the prefrontal cortex, our main focus today. This is the area of the brain at the front end, which is responsible really for higher order functionings like reasoning, planning, decision-making, problem solving, and interestingly for today's discussion, emotion regulation. And it allows for complex thinking and self-control. Additionally, I want to make a mention there, you see highlighted in the schematic, Broca's area is a region also in the frontal lobe of the brain that's primarily associated with speech production and language processing. So you can kind of think between the thinking and the feeling part of the brain of there being sort of this push and pull relationship for dominance between the prefrontal cortex and the amygdala. And that's a relationship that we've partly come to discover through fMRI studies. And so during emotionally charged situations, the prefrontal cortex can help assess the context and, if appropriate, kind of inhibit or quiet the amygdala's response, thus allowing for regulations of feelings of fear and anxiety, which would allow us to make more measured and appropriate reactions to our environment. Whereas the amygdala is really helping us make decisions by signaling emotional significance of situations that the prefrontal cortex will integrate into kind of logical reasoning to guide behavior. But again, you know how I mentioned that push and pull relationship. Sometimes as students, I compare it to the amygdala is like the toddler of the brain, and the frontal lobe is kind of like the babysitter or the chaperone. Under high conditions of stress or anxiety, the amygdala at times can become overactive or essentially hijack control of the brain, leading to heightened emotional responses that can overwhelm the prefrontal cortex. So sometimes in situations like a panic attack, this is kind of our conceptualization of what may be happening in the brain. And this can really impair our ability to think clearly or make rational choices. So it's in these situations that we might look to find tools which we could use to increase the activity of our frontal lobe. You see there with the hand that kind of essentially can push down on the dimmer switch of the amygdala of how active it is. And again, it's that interplay between these two regions that's really essential for making decisions that are not only rational, but also consider the emotional aspects. So again, we're about to jump into some of those tools that we have found can increase frontal lobe activity to help decrease amygdala activity. um, as we're in those heightened emotional states. But we're going to take a quick pause here just to check in and maybe answer some questions before we move into that next portion.
Well, thank you, Dr. Martinez. Very, very informative, and we have a lot of questions coming through here. But whether it be mindfulness or it be affect labeling, if someone doesn't feel like they have the skills or know what that actually is, who can they go to kind of help? And I know there's maybe some confusion on when do I go to a marriage and family therapist, a psychologist, a
Mhm.
psychiatrist? Who can help us with these types of things?
Absolutely. So from my personal opinion, I think that anyone and everyone could benefit from therapy modalities, like what we kind of consider to be talk therapy, like what would be provided by a marriage family therapist, a psychologist, a school counselor. They all kind of offer those. Um, I think, you want to take your car into the shop before it's broken. You want to take it in to get regular maintenance. And there's certain areas that I think everyone has room for improvement in, particularly when it comes to emotion regulation, how we interact with the world, and our relationships with others. So I would say that I would encourage everyone to seek out therapy, at least to give it a try and find out if that's a modality that could be helpful for you. There's also quite a lot of providers who are available in person or online. So there's a fair amount of flexibility there. In terms of connecting with a psychiatrist like myself, the kind of main differentiator there is that a psychiatrist is someone who is a medical doctor, an MD or a DO who specializes in mental health. And that's maybe more in lines when things are at a level where functionality is being impaired at a higher degree, where we might be looking at kind of a differential diagnosis, seeing what areas need support, and considering if someone would be a candidate to benefit from a trial of medications or non-medications, more lifestyle-focused interventions. So I would encourage anyone and everyone to seek out therapy, and then definitely to talk with your primary care provider, whether connecting to a psychiatrist would be of benefit.
Thank you for emphasizing that because I think unfortunately there's this stigma about, really asking for therapy or seeking out therapy. What would you tell the person who kind of feels hesitant, but probably should be in therapy?
Mm, you know, I oftentimes with patients say, like, there's so much data that supports this being helpful. What's the worst that can happen for you giving it a try, even if it's a short-term trial? So, for the situation even of where people are kind of talking about certain lifestyle changes, we're like, I don't think I could run a mile a day. Let's just try taking a 10-minute walk, see if you notice any benefit if you give it a good try for a solid week. So kind of the why not argument, which is probably overly simple, but
It works. It
yeah.
works. So we have a question that has come through. How can a person use affect labeling in their daily life to help their emotional well-being? Does this need to be done just by a professional or can it be done by with trusted friends or even by yourself?
I love that question because this is part of why I really was so profoundly impacted when I was reading the research about affect labeling, because I feel like it's one of the most simple, convenience, mobile, and quick emotion regulation interventions that a lot of times we encourage to make a regular practice and habit. Because the more we do something, the more it becomes our reflex. And so in moments where intensity is high, we turn to that automatically. So I would say you can do it by yourself, even through modalities like journaling or just taking intentional moments to check in with your safe and self and verbally state how you're feeling. It's something I think we naturally do in a lot of conversations, depending on the relationship, where someone's like, hey, how are you? Where we actually stop to take a pause and see where we're at emotionally. And then, particularly for individuals, there's some compromised populations who've, let's say, experienced trauma, a few different backgrounds that would make it a lot harder to practice this technique. I think having a professional help facilitate that can be really helpful and a big game changer for those individuals' relationships, especially.
Well, I love your analogy about the switch. And I think when once that, switch has been turned on, you want to try everything to get it,
Yeah.
under control. So why not? To your point. We have another question that has come through. Are there specific types of emotions, such as fear, anger, or sorrow, that are more effectively regulated by affective labeling?
Absolutely. So even though I don't like to conceptualize of emotions as being positive or negative, maybe a better way to term it is like uncomfortable versus comfortable. I think today in our just general Western society, if someone walks by and they're like, "Hey, how are you?" Our natural instinct is like, "Everything's good." So there's certain emotions that we ourselves and others can be uncomfortable in handling and holding, and that typically is in the realm of sorrow, fear, and anger,
Mm-hmm.
and anxiety, just to kind of add that in there as well. So most of the studies that have been performed that we're going to review in a little bit are really focusing on those uncomfortable or what some people might term negative emotions that are really hard to hold and have more of a correlation of amygdala hijacking when those are high. We gave the example of like a panic attack. Or if anyone is the parent of a toddler, very often you'll see strong emotional moments where you just realize like, hey, their frontal lobe is not the main driver right now.
Another question we had come through is, what if a person is thinking logically but can't stop harmful reactions?
Mm. In that situation, particularly if we've already been able to identify, like, hey, this is my emotion in the moment. Why do I keep engaging in these actions? I'll say that for most people, no matter how negative the action is, sometimes in my field, we'll see things such as like harmful lifestyle habits. Sometimes we'll see self-harming actions. Those are typically engaged in not essentially to hurt ourselves, but because it's helpful in some way. So sometimes self-harming will come in a context where people are feeling too much and they'll engage in those activities as a way to decrease the intensity of what they're feeling, or if they're feeling incredibly emotionally numb, in order to feel something. Or unhealthy eating habits are oftentimes something that can be engaged in as a way to cope with overwhelming anxiety or overwhelming certain emotions. So I try to take a non-judgmental stance on those that they're being engaged in because they're helping the individual in some way, but it can really be harmful long term engaging in these unhealthy coping mechanisms, essentially. So I think that's an arena where engaging with professional help can be really important because our brains get quite stuck into patterns of like, hey, this helps in the short term sense, so I'm going to keep engaging in it, even if long term it's not the best option for me. And so it takes a lot of work to kind of retrain our brain to look towards other types of coping mechanisms.
Another question we had come through was, can you explain how I can be in my office and everything going fine and my anxiety takes over when I'm not logically thinking about anything harmful?
Mm. So in maybe one sense, and I may not fully understand this person's context or where
Mhm.
they're coming from, but for a lot of individuals who struggle with elevated anxiety, particularly panic attacks, we usually classify them as being anticipated or unanticipated. So sometimes anxiety very high is comes along right after you've been in almost a car accident or a very specific trigger. They're like, this makes sense why I feel anxious and shaky. And then in other situations, for a lot of individuals who struggle with anxiety, it comes out of the blue and there's not a good reason for it or a specific trigger that we can identify. So those situations I think are even more difficult to handle because there isn't an identifiable trigger. It can come out of the blue and that makes living anticipating that reoccurrence really scary.
Okay, well, thank you so much, Dr. Martinez, for answering those questions. Why don't we get to the second half of your presentation?
All righty. So now we're going to jump into kind of a portion that I'm most excited to share with you, which is some of the objective data that significantly bolstered my confidence in working to facilitate emotion regulation techniques that my patients can very easily implement into their lives, first and foremost being affect labeling. So, as I mentioned earlier, I really struggled with what I feel is kind of a scarcity of objective data in the field of psychiatric research or mental health research and in our clinical practice. But reviewing these studies and others that we don't necessarily have time to go over today, but I'll reference at the end of this talk, has really bolstered my confidence in recommending affect labeling. So, like any lifestyle change for providers who are watching that you might be counseling on, whether it's related to nicotine, sleep hygiene, exercise, diet, your own confidence as a provider in the utility and potential impact for the change will influence your patients. And for many of my patients as well, learning about some of this data behind the mechanism of the changes we're counseling on can make them be really quite convincing towards following through with the proposed changes. So we're going to go over 3 of these studies, and we'll start off with the first. This is from the year 2000, and essentially what this question or what this study was asking was, now that affect labeling at this point in research had been established through physiological, behavioral, and experimental markers as beneficial, how is it or what is the mechanism by which it's accomplishing this benefit? Which areas of the brain are involved in affect labeling versus other tasks that they're using as a control? So what they did is they recruited 16 UCLA graduates and set up 3 experimental conditions that you'll see here on the screen examples of. One is affect matching, where you're essentially seeing the emotion and choosing which picture most closely matches that emotion, versus affect labeling, putting feelings into words and naming the emotion that you're seeing or experiencing. And the third was shape matching. And they did all of these tasks while their brain activity was being tracked by MRI, functional MRI. And what they found was really a part of what was adding to a growing body of evidence that supported that tasks of affect labeling led to decreased amygdala and increased right prefrontal cortex activity. Whereas matching tasks not engaging with the affect labeling was actually associated with increased amygdala activity. And then building on those previous results, this study from 2007, 7 years later, essentially expanded the number of controls and variables to try and more specifically identify which regions of interest were involved with affect labeling. So in this research study, they recruited 30 individuals, had them complete various tasks with concurrent fMRI monitoring. And you'll see letters D through F are the control tasks where they did gender labeling, gender matching, and shape matching, versus the variables we were most focused on, you'll see A through C up above, were affect labeling, affect matching, and an observation condition, where essentially they were presented with a negative emotion face, and the subjects were instructed just to observe it without actually processing or given any instructions on how to process that. And then through functional MRI, a region of interest was identified in a single cluster in the left amygdala, very sensitive to passive viewing of those single emotionally evocative images and affect matching. So essentially, observing an emotion and matching emotions left someone in a state of high amygdala activity, as you'll note in the red text that I added to the image there. Whereas the results also indicated that affect labeling relative to those other forms of encoding actually diminished the response of the amygdala and other limbic regions to negative emotion images, as I highlighted in green there. So this sort of showed us like the protective nature that affect labeling had compared to other types of tasks that you might engage in to either process or distract yourself from this intense emotional experience. And then additionally, affect labeling produced increased activity in a single brain region of the right ventrolateral prefrontal cortex. So this was kind of showing us as well the beginning evidence that there was an inverse correlation between the prefrontal cortex and the amygdala, starting to give suggestion to the pathway mechanism by which affect labeling may be diminishing emotional reactivity. And that's what leads us to this last study we're going to review today, which was performed in 2013. And this study, again, was really expanding on previous research in the field so as to advance our understanding of the mechanism of what occurs when we're putting feelings into words. And for this study, this is going to look really familiar to you. They recruited 45 individuals and had them engage in these 3 experimental conditions: affect matching that you see by letter A, affect labeling that you'll see by letter B, and then matching forms, all again while undergoing fMRI. And they again found that affect labeling exhibits a dampening effect on the amygdala that is not endogenously present through the ventrolateral prefrontal cortex, and then also presented some additional support for involvement of the Broca's area, whose mechanism you might remember is kind of associated with speech production and language processing, what we use when we're putting feelings into words. And through fMRI, they identified 4 regions of interest that we mentioned already, with the prefrontal cortex, the amygdala, the Broca's area, and then in addition, the right inferior occipital gyrus. And they did a lot of statistical magic here. They created 64 models for each 45 healthy subjects and ran them through dynamic causal modeling and Bayesian modeling to create an averaging pattern down to a winning family of 32 models that revealed a strong endogenous network activity. And essentially through this process, they found one model that outperformed all the others with exceedance probability. kind of demonstrating the affect labeling's most significant regulatory effect on the amygdala originates from the right ventrolateral prefrontal cortex. Yet there's also a few other weaker but still substantial labeling-induced contributions from Broca's area to the amygdala and the prefrontal cortex as well. So again, just giving us a fuller understanding of how affect labeling produces its positive benefits. Again, back to this kind of analogy that the frontal lobe has the ability to turn down the switch or turn down the dimmer on how intensely the amygdala is acting. So that was a lot of our just kind of review of some of the main studies in terms of our objective science or mechanisms undergirding the effective affect labeling. But what I want to touch on before we leave today is really the most important question now, and that is how to actually do affect labeling. So on a practical level, we all know that finding the right language at times can be really difficult, especially when emotional intensity is high or we're already in that fight or flight mode. So in my own personal life and in the clinical setting, I think it's helpful to have a list or a visual aid of some kind to help identify most specifically what our emotional state is. So this, what you see on the screen there, that kind of colorful wheel, is what we call an emotion or a feeling wheel. And you could use this, keep on hand in your office or even on a bookmark for people who practice journaling with affect labeling. Can be just really helpful to have a visual aid to look at, especially when the amygdala is in charge of what's going on. And just as a reminder, verbally stating out loud or writing in other studies were found to be more beneficial than just mentally thinking of or internally labeling that state. Another quick helpful concept I want to equip you with in terms of how to practice affect labeling is to understand the idea of what we call the affect under the affect or secondary emotions. So essentially, secondary emotions are feelings that arise as a response to primary emotions. And that can sound a little bit jarbled and confusing, but we'll use an example to make it a little bit more clear. So think, for example, for the parents out there, you might have a child who does something dangerous which you have been warning them countless times not to do. And initially, you might have a jolt of fear when they engage in that activity, but very quickly after that, you might feel a rising sense of anger and frustration for them not listening to your warnings in the first place. So in this case, the fear was the primary emotion and anger was the secondary emotion. And this visual that you see here is what we call the anger iceberg, because it really helps us conceptualize the fact that sometimes very quickly we lose sight of that initial emotion because there's something else that's a little bit stronger at present on the surface. So this anger iceberg is often used in therapy and conflict resolution settings to help individuals gain insights into their primary emotions. And as a practitioner, facilitating or encouraging affect labeling for a patient, this can be really helpful to keep in mind. And then lastly, I want to draw your attention to some other tools that I think can also help give insight into emotional awareness, which is a really integral part of affect labeling, particularly for individuals having difficulty determining what they're feeling. Sometimes, particularly in certain populations who have experienced trauma or tend to dissociate, identifying emotional states is actually really difficult. So we can turn in those times to bringing awareness into how our bodily sensations, such as areas of tightness or tension, can give clues into our emotional states. And what I find really, really helpful in these situations is to utilize what's called body mapping. So it's a way to relate bodily sensations to emotional states. And in therapy settings, I've even printed out like blank sheets of human figures, and before times of emotional distress, we'll go through and fill out those figures with what they tend to feel in times of intense emotionality. So yeah, it's really kind of in those overwhelming moments that we can begin to practice checking in with our body to figure out how you're feeling, and that'll give us clues so as to name appropriately and harness all the benefits of affect labeling that we've reviewed. So I know that was a lot of ground to cover in a short period of time, but this brings us to the end of our presentation. And just as a quick recap, affect labeling is a psychological technique that involves identifying and articulating one's emotions or feelings. By putting feelings into words, we can gain access to a range of positive outcomes. And research has shown that affect labeling can activate different brain regions associated with cognitive processing of emotions, which will help to dissipate the intensity of the emotional experience. So for example, when we're feeling upset or anxious, simply labeling that emotion out loud or in writing, saying, I feel sad, I feel anxious, can actually diminish the emotional impact and provide us a perceived and a true undergirding mechanism, increased control over that emotional state, kind of taking the control back from the amygdala, which may have hijacked the brain in that scenario. Again, affect labeling can be used in various contexts. It's incredibly simple to teach, simple to implement, particularly if you use an emotion wheel. Remember the concepts of secondary emotions, and when needed, use the clues our body is telling us as well. As I mentioned before, there's quite a number of studies, which I wish we had time to review, but I'm going to post them here and they'll be available in the recording afterwards for those who are interested in learning more. So at this time, I think we'll take a pause and see if there's any more questions that we can answer.
Well, thank you so much, Dr. Martinez. That was a lot of information, but
I know.
fantastic. It was fantastic. We have some questions that have come through, so I'm just going to get right to them. So the first one being here is, are there particular ages or developmental stages where children
Mm.
are most receptive to learning about this type of labeling technique?
I love that question. There isn't much data and research specifically, especially utilizing fMRI, but in other areas of our understanding and data built around child development, we have a pretty fair understanding that the frontal lobe, the area that's most able to kind of help us take control when the amygdala has hijacked the brain, takes a while to develop. Um, there's a great book called The Whole Brain Child, which kind of talks about some of these elements and some of the good techniques that can be utilized, especially in our younger age kiddos who have a lot of difficulty with emotion regulation, which is, by the way, completely developmentally normal. But I think practicing the techniques and giving emotions language as early as you can has potential for benefit because, like any lifestyle intervention, affect labeling becomes a practiced measure that hopefully in the future becomes a reflexive measure. And the more commonly we utilize those things, especially in the beginning when our kiddos are just learning language, that can be really helpful as their brain is maturing and those mechanisms are more able to support that. Because for our young kids, they require a lot of external help in regulating emotions because internally they just don't have all the mechanisms to do that fully in the way that adults do. So that's a great question. And I don't have an exact age cutoff for you, but I'd say probably once we hit our middle school, teenage years, we're starting to see a stronger transition of kiddos really being able to emotionally process at a more complex level.
And what a great skill to have earlier on in life, because I
Oh,
think all of us know adults who can't put their feelings into words, and everyone around them is just dealing with the anger when there is a lot more there that could be helpful to everyone around you to help you. So,
yeah.
yeah.
I think I had one mentor who talked about with that anger iceberg concept, and this is more for particularly adult conversations, but maybe with our teens as well, talking about seeing what emotion was here and then taking a moment to sort of take the elevator down, so to speak, to see if there was another emotion at the core that maybe was the start of this whole situation.
Right. Oh, what a great analogy for sure, or visual. We have another one and we're running out of time, so we might not get to all questions, but this one is actually a very good one. What would you say to people who think therapy and medical intervention is a spiritual failure?
Ooh, okay. That's a pretty profound question in a lot of ways. I will say that I do feel that our spiritual lives and even some of the strengths that we get in terms of emotional resilience, our ability and belief that we can handle the situations that are put into our lives, that we can do all things through Him who strengthens us. I do believe there's a significant amount of interplay, but I also believe, even from some biblical examples, that even individuals who are walking in their spiritual path and in good connection and practicing helpful disciplines of their faith community do still struggle with certain mental health, diagnosable kind of clinical level disorders. I've seen quite a number in my personal practice and just from different kind of literature that's been reviewed. I think that we can't say necessarily that in all cases, increased religious practices is the appropriate prescription to cover everything that an individual might be dealing with. There's been a lot of studies, even for individuals who suffer from depression or who have ended their own lives, seeing chemical level differences between those populations and the, I guess you could kind of say, general healthy control population, showing us that it's not just actions that are made, it's not just choices, but there are at times biological and chemical and genetic level differences that make someone more prone or more susceptible to certain things. And I have also been in situations as a care provider where having an appropriate medication makes night and day difference in how someone is able to handle life stressors.
Right. And that gets to the kind of point where people say, well, this is just all in my head. I need to,
Mhm.
there's could be something um, very physiological happening that you need to talk to someone about.
Yeah. And I will also say, all in your head, all of our life is in our head, how
Right.
we perceive everything at work, all the tasks that we do, our relationships. So, not to discount something that's getting in the way of functionality, if it's work, relationships, school, etc. If it's causing dysfunction, I think that's a flag that we need to give it more attention and figure out what's going on or what areas might need support.
I think that's a really great point to end on. So thank you so much, Dr. Martinez, and thank you all, our audience, for spending a little bit of your day with us. Next month, we will actually be talking to Dr. Corey Fuller, who is one of our adolescent orthopedic surgeons here at Loma Linda University Health. And so with that, I'm going to bid you adieu, and we will see you next time. My name is Dr. Olivia Moses. Have a great day.
All right, we're clear.
Okay. Dr.
Thank
Martinez,
you.
thank you so much. Ariana, that was
Yeah.
fantastic. Your energy
Oh,
was up through the whole thing. It had